Dear seniors, colleagues, and friends, the present era has witnessed development in all fields, whether it is computer sciences, agriculture sciences, or medical sciences. And so is true for GI endoscopy. Today, in this short academic video, we are discussing about a development in gastrointestinal endoscopy known as third space endoscopy, which has brought this field at a different platform and has shown this field glory of new heights.
Dear friends and colleagues, in this video we are discussing about an advancement in therapeutic GI endoscopy which has taken place in last few years, and now it is regularly done in few centers, at least in tertiary and quaternary centers across the country, and is a reality now. Globally it started around a decade ago, and at the same time few centers in India also started performing it, but now it is no more experimental. The prototype of third space endoscopy is POEM, that is per oral endoscopic myotomy. Other third space procedures which are routinely and clinically done are ESD, endoscopic submucosal dissection, and STER, STER, that is submucosal tunneling and endoscopic resection. Third space endoscopy is called when the endoscope is introduced in the submucosal space of the layers of the GI tract, and therapeutic procedures are performed for lesions in the muscular layer, serosal layer, or itself submucosa of the walls of GI tract. It is called third space because first space was the lumen of the GI tract in which we do conventional endoscopy, and the second space was an arbitrary space in the peritoneum or outside the esophagus which was performed by negotiating the scope through the wall of the intestine. Third space endoscopy has gained interest and is now the modality of choice for many diseases in which major surgeries with associated risks was required in past. In this video, we will be particularly discussing about POEM. POEM stands for per oral endoscopic myotomy. It is primarily done for achalasia cardia, but also for a variety of motility disorders of esophagus in which most of the patients have dysphagia of chronic or subacute duration. POEM is now regularly performed by many centers in Delhi and India. Before POEM, esophageal manometry is performed to confirm the diagnosis of achalasia or any disorder requiring POEM. Patient is examined by anesthetist for detailed pre-anesthesia checkup. The procedure is done in general anesthesia and in an intubated state because we need positive thoracic pressure. For performing POEM, an area is recognized at least 6 to 8 centimeters above the lower esophageal junction, and there are two methods of doing POEM. One is a posterior POEM, which is in the posterior part of circumference of the esophagus, and anterior POEM is in the anterior part. Usually posterior POEM is performed because it is technically easier and with a fewer complications. At the start of POEM, the mucosa is elevated with submucosal injection of indigocarmine and an incision is given in the mucosa.
This is the site of puncture, which is made by a 21G injector needle. Around 15 to 20 ml of indigocarmine is injected in the submucosa, which forms a large bleb, and with the help of a TTJ knife, nick is given on this bleb. A sufficient space is created, and through this entry point, as we can see, the scope is negotiated into the submucosa. In the screen, towards 11 o'clock is the mucosa, towards 5 o'clock is the muscle layer.
After reaching the submucosal space, a tunnel is formed by a gradual dissection of submucosa with the help of repeated injections and a particular knife which is known as
TT knife
or hybrid knife, which has a facility of cutting and injection for inflation of submucosal space so that easy dissection can be performed.
As we can see, this TT knife is performing a dissection of submucosa. This is the injection of indigocarmine in the submucosa. This gives a blue hue so that the space is identified, a perforating vessel.
Particular care is taken to avoid injury to mucosa and blood vessels. If there are some vessels, they are caught with an accessory called coag and it is cauterized and removed from the area of dissection.
Vessel caught by coag coagulated and cut.
This tunnel is extended up to lower esophageal sphincter and 3 to 4 centimeters beyond that in the stomach in the submucosal space. After formation of this tunnel, the muscle layer, usually both circular and longitudinal muscle layer, is incised starting 2 to 3 centimeters beyond the entry point from the mucosa and extending up to the tip of the tunnel. Incision of muscle layer leads to relief in the resistance at lower esophageal sphincter and thereby relieving dysphagia.
This TTJ knife performing myotomy. The muscle layer is elevated with T knife and is incised, giving a slight traction towards mucosa. Here the particular care is needed to avoid injury to mucosa. Towards lumen is the circular muscle and outside is the longitudinal muscle. Likewise, myotomy is performed till the tip of the tunnel.
After incision of muscle layer, an antibiotic solution is sprayed in the tunnel to avoid infection and scope is withdrawn from the tunnel. Then the luminal aspect of esophagus and stomach examined. During examination through the luminal aspect after the formation of tunnel and incision of muscle layer, we can realize that there is no resistance at lower esophageal sphincter, which is the hallmark of eclasia cardia and thus signifies the response to the procedure.
After complete myotomy, the wound is closed using hemoclips. Around 7 to 8 clips are used to completely close the mucosal gap.
After the procedure and extubation, the patient is kept fasting for at least 18 to 24 hours and thereafter a gastrographin study is performed to see if there is any leak into the mediastinum or peritoneum. When we confirm that there is no leak, patients are started with clear liquids first and gradually the content and the quantity of intake is increased. Patient is usually discharged on second or third day of the procedure and total duration of hospitalization is usually 2 to 3 days. Few patients may have reflux symptoms after the procedure, but in majority they can be managed by proton pump inhibitors or prokinetics. Need for fundoplication for these reflux symptoms after POEM is very uncommon and rare. In majority of the patients, the response to POEM is durable. As is true for any other medical procedure, complications may happen. Free air or capnoperitoneum and capnothorax are present in 80% patients. But sometimes there is tension pneumoperitoneum which can be aspirated by fine needle. Tension pneumothorax happen in 3% patients. Rescue clips, whether they are for mucosal injury or bleeding spots, have to be used in around 1/3 of patients and around 5% patients may require stent placement for tamponade defect and perforations. Failure to achieve the desired response is very uncommon and rare. POEM was first reported from Japan in 2010 by Inouye et al. And this group performed POEM in 17 humans successfully. As far as literature is concerned, there have been many landmark trials. The trials in the later years compare POEM head to head with either balloon dilatation or Heller's myotomy. In this list, it is apparent that POEM rates better as far as the technical outcome, success rate, lower complication rate, or ease of doing and being less invasive over other procedures.